workshop, a continuation of this highly insightful learning experience. This session is titled Pitfalls in Imaging in Spondyloarthritis and will be facilitated by Dr. Ghita Harifi, consultant rheumatologist and adjunct assistant professor at Mohammed bin Rashid University of Medicine, UAE. Dr. Harifi brings extensive expertise in musculoskeletal imaging and clinical rheumatology. And today's session will highlight the common challenges and interpretive errors clinicians may face while assessing imaging spondyloarthritis, along with practical strategies to overcome them. We encourage all participants to stay attentive and interactive as Dr. Harifi takes us through the important and engaging session.
Well, I'll have to do it even for a few people attending. Yeah, so I would like to start by thanking the organizers for inviting me to take part in this fantastic meeting, as it has been described previously. I took a tremendous pleasure in the yesterday's sessions and in attending today's sessions, in yesterday's workshop and then today's sessions. So thank you very much, and thank you for those who have stayed back, the few attendees who are still here. So without further ado, we'll take you now. We're moving from clinical parts. We've been speaking about spondyloarthritis this afternoon, and we'll move to the imaging part. And as you know, when it comes to spondyloarthritis, imaging comes in the heart of the diagnosis. And so I've been given the task to talk about pitfalls of in imaging in spondyloarthritis. And the first thing I would like to start with is, what is a pitfall? So a pitfall is an English word for a trap or a hidden hazard. But when you're dealing, a pitfall in imaging can have some significant consequences on patient's management. Like you see in the cartoon, this ER nurse was wondering if, not knowing how to read the doctor's handwriting, he was wondering if the patient was either released or deceased. So conceptually, there are 3 types of pitfalls. So the first type is perceptual errors, meaning failing to see an abnormality. The second type is cognitive or interpretive errors. This is when we see the lesion, but we misinterpreted the lesion. So what is seen. And the third type of pitfalls is related to communication errors. So perceptual errors is when we fail to see an abnormality. And with this, I would like to invite you to take this test with me, and I'm going to give you 3 seconds to try and tell me if you see any abnormality about this scan, this lung scan, CT scan. Well, you're amazing. You're actually outstanding, because Dr. Asim has spotted a gorilla on the top of the, is this working? On the right top of the image. While actually Harvard researchers have shown that more than 50% of radiologists fail to spot the gorilla on this scan. This is called the gorilla test. Sounds, silly. How is it possible that there is a gorilla on the image and we don't see it? Well, in this groundbreaking study, the radiologists were in a lung nodule detection task. They were not looking for gorillas. So this is called inattentional blindness. And this means that when we are focused on looking at something or looking for a specific lesion, we might miss others. Second type of pitfalls is cognitive or interpretation errors, and these are probably the most common ones. So these are the ones that we call usually, lead to false positive when we overdiagnose due to differential diagnosis or artifacts or coincidental pathologies, or to false negative when we miss the diagnosis or we underdiagnose due to lack of knowledge of pathology, wrong anatomical area scanned, or misinterpretation of artifacts. And then we have the communication errors. And here comes something that we call the framing effect. The framing effect is a cognitive bias in which people base their decisions on their conceptions and their perspectives on whether options are presented with positive or negative connotations. So basically, like here, the psychiatrist would like to nuts on his rails, the plastic surgeon wants no wrinkles on her bacon, and the fertility doctor wants his eggs frozen. So at the end of the day, radiologists are humans, and their interpretation has something to do with their perspective and the way they look at the image. And until radiologists are totally replaced by AI, we will be dealing with some framing bias still in imaging reports. And I think that one of the typical situations that we rheumatologists dread the most is to get a report like this saying arthritic changes seen in sacroiliac joints for further clinical correlation. We hate that. If there are any radiologists in the room, I doubt, just be aware that we rheumatologists hate these kinds of conclusions. Now, let's go to the MR imaging of sacroiliac joints and spine enthesitis. And you know that in the ASAS criteria, imaging is absolutely central in the diagnosis. This is part actually of the criteria, and whether it's radiographic sacroiliitis or an MR proven sacroiliitis showing inflammation. So this is absolutely crucial for the diagnosis. Now, let's start with the basics on MR imaging and what are the sequences that we'll be looking at as rheumatologists. Basically, focus on T1 and STIR. Most of the MR imaging for rheumatology will use these two sequences. How to differentiate between the two of them. So keep it simple. In T1, you look at two things actually, the spinal fluid and the subcutaneous fat tissue. In T1, spinal fluid, water, is hypointense, it's dark, and the subcutaneous fat tissue is bright. On STIR, the spinal fluid is bright and the subcutaneous tissue has been suppressed, so it's bright. So basically a STIR is a T2 on which we have suppressed the fat. So this is how we will actually differentiate. We're not radiologists at the end of the day, and we need to keep, to be reminded of the basics of these sequences. This is a T1, how we recognize it. Spinal fluid, black, and subcutaneous tissue, hyper-intense. STIR, spinal fluid is bright, and subcutaneous fat has been suppressed and it's dark. So these are the two sequences that we'll have to deal with. Now, let me take you to a very short tutorial on how to read an MRI of the sacroiliac joints before we go to what is it is a pitfall or a wrong image or an artifact. So imaging of the sacroiliac joints is conducted in the tilted semi-coronal plane so that MRI slices are parallel to the posterior border of the sacrum. Why? This is aimed at depicting the cartilaginous portion of the joint. So these are basically the slices that we'll be having. So semi-coronal slices and semi-axial slices. Now, how does a normal sacroiliac joints MRI sequence looks like? So on T1, so this is a T1 sequence, again, subcutaneous fat is bright, and spinal fluid is not seen here, so vessels are dark, and T1 are the best sequences to look at anatomy and to look at structural changes. So remember, T1 is to look for things like erosions, sclerosis, and fat metaplasia, basically. STIR will, the fat is suppressed, and this is basically to see, this is the STIR sequence detects the signal from free water. So blood vessels and cerebrospinal fluid therefore appear bright, and the signal from fat is suppressed. So basically, by combining T1 and STIR, you will be able to detect active and structural changes. Active inflammatory lesions on STIR and structural lesions on T1. And basically, usually, T1 and STIR scans should be always viewed simultaneously. Like in here, we have usually, softwares that allows us to do this. And, on T1, you can detect fatty metaplasia, in here, you can detect erosions, so structural changes. And on STIR, you can see that this area that looked black in here is bright. So this is bone marrow edema on STIR, and showing you an active disease on both sacroiliac joints. And you see here that you have both structural and active lesions in these patients. And you can conclude that there is a sacroiliitis. So the AMR changes in sacroiliac joints, the inflammatory changes, can be osteitis. Osteitis is another word to describe bone marrow edema, okay, within the bone. And then enthesitis at the insertion of ligaments and tendons. Synovitis, which is an intra-articular signal, bright signal, and capsulitis, like in here on the top image. So these are the inflammatory changes that you can see. Let me remind you that for the ASAS criteria and OMERACT criteria, the definition of sacroiliitis is that you have at least two bone marrow edema lesions on a single slice, or one bone marrow edema lesion on two consecutive slices. And things like synovitis, enthesitis, and capsulitis are valid, compatible with the diagnosis, but they're not considered sufficient to conclude for the sacroiliitis. And this is, I think, one of the limitations of this definition, because we will see that we'll have some patients who do not have typically bone marrow edema in the sacroiliac joints, but they have clear sacroiliitis. And I mean, it's rare, obviously, synovitis and capsulitis, etc. It's rare to have them without bone marrow edema, but this does not mean that they don't have inflammation in the sacroiliac joint. Now, this is a 23-year-old male patient with 2-year history of inflammatory back pain, a normal pelvic X-ray. And you can see here, I won't, since we are a few in the audience, you can tell me if you think that this is sacroiliitis or not. With a raise of hand. You have a comment? Yeah, so we do see here both on T1, we see structural changes, we see fatty metaplasia, we see significant erosion here. And on STIR, we do have features of capsulitis, joint space inflammation, and bone marrow edema. So this is definitely a sacroiliitis, and spondyloarthritis. Obviously, we have the diagnosis, and we can also say that it's an active disease because we have significant features of activity. Now, minor degrees of bone marrow edema may be seen even in healthy individuals. And you see, this is a healthy volunteer, 35-year-old female, married, no children, no history of back pain or pelvic pain, normal weight, normal activity, not an athlete. And you see, on STIR, we have some bone marrow edema on more than one slice. Now, another pitfall is this, and if you I would like to ask you if you think that this bone marrow edema here, this bright signal, is significant for sacroiliitis in this case. Okay, so this is not enough to say that it's sacroiliitis. Well, I agree with that. But also, if you look at the image, you have a transitional vertebra here with partial sacralization of L5. This is not an uncommon situation. This is quite common, actually, to have a partial sacralization of L5 with more biomechanical stress on this region. So these people are expected to have some bone marrow edema on this. And it can be actually causing some back pain and significant back pain. So be aware of this possibility of having bone marrow edema, which is due to biomechanical stress. And in fact, studies have shown that athletes can have significant amounts of bone marrow edema. And in 30 to 40% of subjects, of these young athletes, this bone marrow edema can fulfill the ASAS criteria of active sacroiliitis. So we need to be careful, and we need to take a good history, and we need to be a little bit, critical when it comes to the interpreting images on bone marrow edema, because we may overdiagnose. And this is one of the criticism that we give now to this definition, and that's why this definition, the ASAS definition of sacroiliitis, is expected to be modified soon, because we think that by exclusively taking the bone marrow edema as a criterion, we overdiagnose patients. Okay, we'll have to have, and the direction we're going to now is we will probably need at least some structural changes and to show an erosion at least to conclude to sacroiliitis. Now, just to give you a tip here, when it comes to athletes and you're looking at bone marrow edema or where you see it, be aware that the posterior lower ilium is mostly the area affected by mechanically induced bone marrow edema most of the time. So if you see that bone marrow edema is concentrated in this area, then, in an athlete, then think twice. Now, moving to fat deposition. Is fat deposition something specific for sacroiliitis or spondyloarthritis? Now, the answer is no. Fat deposition is diffusely. You can see here, this is in healthy individual, and you can see that this is a significant fatty deposition. What is the characteristic? The fat deposition here is diffusely distributed throughout the sacrum, and this is quite commonly seen in healthy individuals. What is the difference between the fat infiltration that we see in spondyloarthritis? Well, in spondyloarthritis, the fat infiltration is usually very close to the subchondral bone, and it usually has a distinct border with this proximity to subchondral. You see the difference between this and this. So usually very close to the joints, to the joint line in the subchondral bone. Fat infiltration and bone marrow edema can coexist, and we can have this simultaneously, like you see here. And on the same area where you have fat infiltration, when you move to stir, you see some bone marrow edema. And this means that this patient is probably having at the same time some ongoing inflammation with some chronic inflammation as well. Backfill, so looking at structural changes, backfill is something that we actually stressing on more and more, and we think and we expect that backfill will be added to the definition of the structural changes of the definition of sacroiliitis. So what is backfill? Backfill is basically a new tissue that is equivalent to fat metaplasia, but the difference here is that it fills the excavated bone erosions. So backfill comes within the erosion. It's regarded actually as a sign of healing and a new bone formation in the sacroiliac joints. So usually seen on T1 sequences. Other structural changes are erosions, and sacroiliac erosions should be assessed, on T1, as you know, and you can see here multiple erosions associated with sclerosis and pseudo-widening of the joint space due to definite erosions in the left iliac bone. This is actually what leads to the pseudo-widening that we know of. Now, we might have some limitations, or the conventional MR imaging might be limited in detecting erosions. And that's the reason why since 2017, 2018, there has been an effort put in defining or in coming up with new sequences which are more sensitive to show erosions. And we have now the high sensitivity sequences for detecting erosions in the sacroiliac joints. One of them is quite famous now, called VIBE, volumetric interpolate breath hold examination. So what is this? This is basically a 3D imaging versus the 2D imaging that we usually do with T1. Instead of having a 2D imaging, we have a 3D imaging, which offers a greater sensitivity than standard 2D T1 sequence to detect erosions. We call it VIBE, commonly, but VIBE actually is the term used by Siemens, the machines at Siemens. If you use a Philips machine, it's going to be called Thrive, and GE calls it Lava, but basically the same sequences, very thin sequences, 1 millimeter slices thickness or less, 3D volume database with a high contrast for articular cartilage and high sensitivity in detecting erosions. Now, moving to spine, how to interpret spine and see an MRI imaging of spine. So this is a normal spine T1 sequence. Again, fluid is black and fat subcutaneous tissue is bright. On STIR, you see the fluid, the spinal fluid is bright on STIR. And so the MRI can show you inflammatory changes like in here. So these are extensive changes, MR changes, and not just corner inflammatory changes. This is called a massive inflammatory lesion, which is basically when the bone marrow edema goes from anterior to posterior continuously. Now, the important point about MRI in the spine is that you need to be able to look at the lateral parts of the spine. Like you see here, there are multiple foci of inflammatory changes or bone marrow edema that are more probably here in the costovertebral area. So if the radiologist didn't go that lateral to take these joints, we would have probably missed the inflammation in this patient. So it's very important because routine imaging of the spine for neurology and neurosurgery and orthopedic specialties typically focuses on the central sagittal slices and doesn't go that lateral. So do ask your radiologist, please, to include the costovertebral and costotransverse joints when it comes to in spondyloarthritis patients, on patients suspected to have spondyloarthritis. Now the definition, the ASAS definition says that you have to see these changes at least in 3 or more sites in highly suggestive axial spondyloarthritis because, again, active spinal lesions can be seen. This kind of, 1 or 2 vertebral corner lesions with bone marrow edema can be seen in healthy individuals. Bone marrow edema can also be seen in degenerative disc disease. This is quite common. What about fat infiltration? Fat infiltration in degenerative disc disease is quite common. So you can see fatty metaplasia around, areas where there is disc degeneration. We can detect erosions also on MRI spine, and in some situations they can be very impressive, like in these patients, and we showing also inflammation around erosions. In the MRI spine, be aware also of the pitfalls related to blood vessels. So you have the vertebrobasilar vessel that comes in here, and sometimes you have hemangioma. So do not take this for inflammation, please. Now, in some situations, in metastatic deposits can look like fatty metaplasia, but the normal marrow conversion is slightly different than the metastatic changes. You see, this is a patient with lymphoma, and you can see that both fatty metaplasia and bone marrow edema in STIR are visible bilaterally, but when you analyze the fatty metaplasia, you see that it's quite heterogeneous. So be aware of these kind of pitfalls. Infections usually give, when in the context of sacroiliitis, gives a presentation or a clinical picture of unilateral sacroiliitis. The particularity here is that usually the edema or the inflammatory changes crosses the anatomical borders of the joints and go beyond the joints, and sometimes, this is what we see in infections like in TB or brucellosis, etc. This is one of the situations where rarely, we need to inject gadolinium in case of doubt. Another common pitfall is osteitis condensus ilii in patients with multiple children, and you can see this is the typical triangular sclerosis, bilateral sclerosis, better seen on CT, and it gives a dark image on T1 like this. And you can see the characteristics here is that the sacroiliac joint line remains intact. Trauma and athletes as well can lead to vertebral or sacral, fractures, like in here, seen with a lot of bone marrow edema around. So if the acute onset pain in the sacroiliac joints or lower back, think of this. Some false negative as well. So this is a patient, again, without diagnosis of sacroiliitis, doesn't fulfill the criteria of sacroiliitis, but you can see, not in the sacroiliac joints, but she has a bilateral posterior sacroiliac ligament inflammation and thesis. So this is the situation where you have pelvic enthesitis, but you don't have any changes in the sacroiliac joints that would fulfill the criteria. Nearly 1/4 of spondyloarthritis patients are in this situation with suspected sacroiliitis, showed pelvic enthesitis on MRI, and which is believed to have a high sensitivity for the diagnosis of spondyloarthritis. Again, false negative, no sacroiliitis on MRI. When you have no sacroiliitis and a high probability, a high pre-test probability for spondyloarthritis, do image the spine. Okay, so this is a patient, if we hadn't done the spine, we wouldn't have seen this massive inflammation in the thoracic spine. So take-home messages here is that we as rheumatologists should be able to read our MRI, sacroiliac joints and spine. And I think that many of us have done this effort in educating ourselves in reading MRI, spine and sacroiliac joints. MRI has a significant role in early diagnosis, obviously. Bone marrow edema, fatty degenerations are not specific. They can be seen in non-inflammatory conditions. The definition, the ASAS definition right now of the sacroiliitis is meant to be modified soon with probably more structural changes required for the diagnosis to avoid over-diagnosing patients because of bone marrow edema. And enthesitis, be aware of enthesitis and look for enthesitis in the pelvis. And I would say mostly in young patients. The youngest are your patients, and this is the pediatric rheumatologists are aware of that. Pelvic enthesitis is quite common in adolescents and teenagers with early inflammatory spondyloarthritis. So I think time has come that we reconcile with the radiologists and we work together. I think it's very important, and this was a nice article about the efforts between radiologists and rheumatologists. I think it's important to pick a good musculoskeletal radiologist, to trust your radiologist, but don't be a lemming. Lemmings are known to commit massive suicide because, they jump the cliff and then others follow. So don't be a lemming. It's sometimes good to be the black sheep. It has some advantages. So assume nothing and question everything. And my best advice, I think, is make friends with your radiologist. You will need him, definitely. Thank you very much for your attention. And if there are any burning questions, I know this is quite a heavy program for you today. No questions? Yes. Dr. Ibrahim, thank you. Thank you, Dr. Asim. Tell me.
Lecture. So
I know
it was very fantastic.
I tried to do it, to kind of, push it in everything in 20 minutes. It wasn't easy.
Yeah, it's very difficult, but it's very well done. Thank you.
Thank you, Dr. Asim. Thank you very much.
Thank you so much. Great, as usual.
Thank you.
Question that is not a question, maybe a comment. You said that maybe we need to upgrade or modify the criteria that we have now. I totally agree. Yeah. Bone edema alone sometimes is over, and it's high sensitive, but for me, yes, I agree with you, it's not specific. Yeah. But in other way, if we wait until we see the bone erosion, which is the specific for sacroiliitis, I totally agree, but this is for me is late as a rheumatologist. We need to prevent this. Don't wait until we see the bone erosion.
Well, that's a great comment. You know, one of the reasons why the initial definition had only bone marrow edema and they removed the structure changes is this. We came from an era where we had to wait for the New York criteria to have bilateral sacroiliitis or grade 2 or unilateral grade 3 to diagnose our patients. So we wanted to be really early in the diagnosis, and that's the reason why we choose to be very sensitive in the beginning. But we have to admit that over the last 15 years, probably 10 or 15 years, we have also been seeing, and I see those patients in the clinic who have been given the diagnosis of spondyloarthritis just because they have one slice, tiny bone marrow edema on one of the slices. They have absolutely nothing inflammatory. They're HLA-B27 negative. They have no inflammation. And when you analyze the pain, sometimes the pain is not even inflammatory, and they've been given biotherapies. So I think it's important that we find the right compromise. I totally agree. And that's why we're not talking about erosions that are seen on X-ray or on CT. We're talking about small, tiny erosions that are only visible on vibe sequences. So we'll have to find a compromise. This is always the case in imaging. But yeah, brilliant comment. Thank you. Thank you very much.
I would like to invite Dr. Muhammad Arshad, consultant rheumatologist at Spring North Hospital, Lahore, and Dr. Asim Khurshid, also consultant rheumatologist at NHS Foundation Trust, United Kingdom, on stage to present the souvenir to the facilitator, Dr. Ghita Harifi. Please join us on stage. Thank you, everyone. This marks the end of the imaging workshop.